Welcome to today's lecture on lower GI problems. To start off with, we're going to talk about acute abdominal pain. There are so many causes that even the book can't list them. Really, it's a recent onset of pain, could be an emergent condition and require immediate attention, or it could be gas. In reality, that's not really it, but there's such a broad spectrum of causes that it is one of the main reasons that people come to the emergency department, and it's our job as medical personnel to find out the cause. Some possible causes: inflammation, infection, bleeding, obstruction, perforation. There's so many different options. Pain is the biggest complaint, but they also might be experiencing nausea, vomiting, diarrhea, flatulence, fever, bloating, fatigue. And we need to know as much as possible about this patient's pain. How long has it been happening? The duration, the location, and really any other symptoms. A good example is nausea and vomiting for 3 days, maybe fever for a day, really trying to find out where their pain is located. Then you really are going to do a physical exam. You're going to start with inspecting, then you're going to auscultate the bowel sounds, palpate for the tender areas last. Remember to observe the patient's face while you are palpating. That'll be a good determination of how bad their pain is. There's some people you will literally touch and they jump at the pain. There's some people that will be texting while you are palpating, so that gives you a big tell. And then you're going to do a bunch of different kind of labs and diagnostic tests, really considering like a CBC, a urinalysis is the CUTI, an abdominal x-ray to start off with, maybe an ultrasound, a CT, if they're a woman and of childbearing age, a pregnancy test, really to rule out things such as like an ectopic pregnancy, which is a pregnancy that's outside of the uterus. And then we're going to look at treatment. You are going to find the source of pain and relieve that pain. You're going to resolve inflammation, reduce the risk for complications such as shock, and return to baseline nutritional status. Sometimes surgery is needed, like an exploratory laparotomy. This is where they do tiny little sites and they go in via surgery to explore the area. This is for emergency management of acute abdominal pain, and the patient might also need things like an NG tube or be NPO for testing and surgery. So there's a lot of different goals to do with this treatment. Diarrhea, it's mostly commonly caused by like viruses and bacteria. Really, we want to do like a stool specimen if they're having long-term diarrhea, find out what's occurring in their stool. They're probably going to be like fluid loss, so you're worried about dehydration, hypovolemia. We're worried about like spread of infection. Is this, for example, C. diff, which is a antimicrobial diarrhea that it really does not react to most antibiotics? Or is it like skin breakdown? Are we worried that they're having so much diarrhea, maybe they're elderly and they can't wipe themselves, or they're wearing briefs and they start to have skin breakdown? So those are some of the concerns when we're thinking of diarrhea. Another big lower GI issue is constipation. Really, there's a lot of things that this can be caused by. Maybe it's opioids, a patient post-operatively that is taking that pain medicine that is really slowing down their GI system. Maybe a hospitalization, decrease in activity, a decrease in fluid intake, and really a dietary deficient of fiber. One of the big goals first is nutritional therapy. Nutritional therapy is more conservative and preferred over drug therapy. We want to increase dietary fiber and fluid. That's the gold standard. Fiber is found in fruits, vegetables, grains, those kinds of things. So really, patient teaching is often involved in this therapy. It can also be drug forming or drug therapy, such as bulk forming, such as Metamucil, osmotic solutions such as Golightly or Miralax, stimulants such as Senna or Dulcolax, and stool softeners such as Colace. Many people that are post-operatively are automatically put on some kind of stool softener, and in the hospital situations where nutrition therapy may be not as fast as we need, then we're going to go ahead and start all these people on some kind of stool softener or some kind of fiber just to kind of help them out while they're in these situations. Abdominal trauma. Really, there's common injuries that we see with abdominal trauma, such as a lacerated liver, a ruptured spleen, mesenteric artery tears, diaphragm ruptures, urinary bladder ruptures, renal or pancreas injuries, stomach intestinal rupture. There's really a lot of things that can be happening. Blunt trauma occurs with motor vehicle accidents is one of the big ones. Maybe a beating like a fight or a fall. A fall might not be really obvious, especially with the elderly. Damage usually is more internal with no obvious external cues. That's why abdominal trauma can be really the most dangerous, because they may look fine, they might feel fine until they're not fine. A lot of times we can see like compression and like shearing injuries that occur with blunt trauma. You might see a penetrating injury such as a gunshot or stabbing where there's an obvious open wound. Really solid organ damage such as the liver, spleen, kidney. Really we're worried about bleeding, especially with the liver and spleen where there's a high blood volume to that area. We're going to watch for hypovolemic shock, that sudden loss of blood that we can't see externally. If contents from hollow organs like stomach or bladder spill into the peritoneal cavity, then we're at risk for peritonitis, which is that infection of the bowel. Clinical manifestations we'll talk on the next slide, but diagnostic tests could be like a CT scan, a CBC, urinalysis, ABGs, just to kind of see what's going on in that area. Emergency management, this is big when you're thinking of exam questions, because when there's an emergency such as your ABCs, your airway, breathing, or circulation, those take priority over everything else. So we're going to secure an airway. We're going to give IV access, which think IV access means circulation, where we can give them blood and fluid replacement to combat the hypovolemia. Symptoms of abdominal trauma, it could be guarding or splinting of the abdominal wall. Usually that's possible peritonitis or some kind of inflammation and infection in the bowel. A hard distended abdomen. You might hear the word rigid board-like abdomen. This is possibly an internal bleeding, so this is a big obvious issue, probably one of the most scary issues. You could hear decreased or absent bowel sounds. That could be because of blood blocking those bowel sounds, your body automatically not wanting to have spend the energy to have those bowel sounds. You could see contusions, abrasions, or bruising over the abdomen. You could obviously hear the report of abdominal pain. Maybe pain over the scapula due to the phrenic nerve irritation by free blood in the peritoneum. Hematemesis or like the hematuria, and signs of hypovolemic shock. Colons and Graves Turner signs are some of the big signs of internal bleeding. Colon sign is the ecchymosis around the umbilicus and superficial bleeding underneath the skin. And then Graves Turner sign is the ecchymosis around the flank area. Can happen due to trauma, ruptured ectopic pregnancy, aortic rupture, or even pancreatitis. Both are indications of what we call a retroperitoneal hemorrhage. Retroperitoneal means behind the peritoneum and outside the peritoneal cavity, so it's kind of hiding back there. Example of this could be an MVA or a motor vehicle accident where you see the obvious maybe seatbelt signs and you're worried about other things, but you don't see the bruising behind the patient. This is why it is big in these emergency situations to turn your patient and look at the back. Some people are afraid to do this maybe because you're worried about like the cervical C-spine. Well, they should have a collar on. And that collar is to keep them stable so you can turn the patient and look for these signs. I've seen a simulation run with this with ICU nurses where 98% of the nurses actually miss the bleeding behind. Intestinal obstruction. Really, there can be a lot of different etiology and pathologies behind this again. It could be maybe a tumor that is blocking the abdominal path. Maybe it could be some actual constipation that's blocking everything. It could be a twist in the gut that's causing a lot of issues. But the actual obstruction really still manifests in some certain ways. So the clinical manifestations include nausea, vomiting, abdominal pain, distension, and constipation. Bowel sounds are usually high pitched above the obstruction because that's the bowels trying to get things to get moving, and then hypoactive below the obstruction because there's nothing moving through. This is why it's really important to document when you auscultate like each abdominal quadrant, and they actually say to do it for at least a minute if these are your concerns. Usually you will see like normal temperature, not any other issues unless you see a strangulation, which is that twisting of the bowel, or perforation. Diagnostic studies, we're going to do an X-ray, CT, CBC, see what we see, and what our blood is telling us. And then collaborative care, emergency surgery is needed if there's like strangulation that can happen, but otherwise can really be treated conservatively. Really, we really want to get in these emergency situations of the strangulation, you want to get blood supply returned to the area or it's going to become necrotic and die. So that is an emergency when it is strangulated. Otherwise, we're going to do NPO. Obviously, we don't want to give them more things that are going to cause the obstruction to be worse. We're going to hydrate them with IV fluids. We're going to put an NG tube down and decompress that area and give them pain medicine because it is very painful. Surgery can be done if there's no improvement made in 24 plus hours. They can resect the bowel or even use a scope to remove polyps. You can put in a something to dilate that stricture if there's a stricture. Really, they try conservative first. If there's no improvement, then we're going to do surgery. So as you can see, there's different types of bowel obstructions. A shows a great example of an adhesion. This is a scar tissue formation, usually after some kind of other bowel surgery or abdominal surgery that causes scar tissue to form, which then overlays on top of the bowel, which causes an obstruction. You could have a strangulated inguinal hernia. That is where the bowel actually falls into the inguinal area and is strangulated because it can't get out. This can be a medical emergency. C shows a great ileocecal intussusception. Really, intussusception is the slipping of one part of an intestine into another part just below it. This is most common in infants. It is also known as the telescoping of the bowel. So if you think of the telescope when it is extended out, what the bowel does is it kind of, when you collapse that telescope, you know, those pieces go in on each other or itself. That is what intussusception is. This must be treated within 24 hours because it can cause bowel injury and actually death in long term if it continues to be an issue. You can see D is a intussusception from polyps. Those polyps cause the bowel to actually do that scoping on itself. You see E, which is mesenteric occlusion. So that could be the mesentery, which is the different adhesions within the body that causes that kind of obstruction. Maybe it's F, a neoplasm, or which is like a tumor or cancer that is pushing in on that bowel. Or G is a volvulus of the sigmoid colon, really the twisting of the bowel on itself causing an obstruction. So this bowel kind of gets loose, it twists on itself so nothing can get past it. This can also be an emergency. Really, there's mechanical and non-mechanical. Mechanical, the most common causes is the surgical adhesions, maybe a hernia, stricture from Crohn's disease, or cancer. Non-mechanical occurs with reduced or absent peristalsis caused from neuromuscular or vascular disorders like a paralytic ileus. Now we're going to talk about the different inflammatory disorders. The first one is a very common one a lot of people know about is appendicitis. It is a periumbilical pain, nausea, vomiting, usually will radiate up to the right lower quadrant, or down, sorry, to the right lower quadrant. You'll have some like localized tenderness, muscle garden, and rebound tenderness. So rebound tenderness is one of those main signs. This is sudden pain when the fingers are withdrawn quickly. So you put pressure, when you withdraw your fingers, that's when they have pain. Patient will sometimes have like a low-grade fever and really doesn't want to move because they are uncomfortable. That right lower quadrant pain specifically is called McBurney's point. It's halfway between the umbilicus and the right iliac crest. Like we were saying, the patient doesn't want to move at all, so they usually want to lay flat with no incline, and they're guarding those muscles. Usually their right leg is drawn up, if not both, into like the fetal position. You'll see elevated white blood cell counts due to that inflammation and possible infection. CT scan and ultrasound confirm diagnosis. Treatment, we are surgically removed with localized infection. So the surgery is actually called an appendectomy, or you might hear it called maybe like an lap appy or an open appy. Lap appy means they go in laparoscopically, so they have like 4 or 5, sometimes even 3 little tiny incisions that they go in, and they put in scopes they can see in through the abdomen. An open would be where they actually cut it open. Really, we're going to focus on pain management, monitoring vital signs, and administering antibiotics as ordered, and maintaining fluid status, and giving antiemetics. The nausea and vomiting after surgery can be more painful because when they're vomiting, they're moving that abdomen, which causes a lot of pain. If ruptured, this is a big reason for peritonitis. So we're going to do IV antibiotics and IV fluid therapy, usually 6 to 8 hours before surgery to reduce risk of sepsis. Sometimes even longer. I've seen 24 to 48 hours, but for now the textbooks are really saying 6 to 8 hours. You're really wanting, before they go in and do some incisions, they're wanting to try to resolve that peritonitis. And unless it's an actual peritonitis where they're like ruptured and having lots of bleeding or something like that, or they're not stable, then we're going to try IV antibiotics and IV fluid therapy first. Peritonitis, you've heard me talk about it quite a bit throughout the last couple of PowerPoints. It is the inflammation and infection of that peritoneal cavity. Really, there's a primary and a secondary. Primary is the organisms enter the peritoneal cavity straight away, like there's no other kind of cause. This is pretty rare, but one of the biggest examples is peritoneal dialysis, which we'll talk about later in the actual semester. I think it's in Unit 4. But the peritoneal dialysis catheter gives dialysis straight to the peritoneal space. So this would be like an infection in that fluid going straight into the abdomen. The most common cause, though, is secondary. Usually occurs from a rupture of abdominal organ, and contents from inside the organ are spread throughout the peritoneum. So, for example, we just talked about the appendix. It ruptured as it goes in the bowel, maybe a bowel rupture, ulcers, gallbladder, like we talked about earlier, trauma. So maybe a puncture with a knife that goes straight into that area and brings that kind of infection. Symptoms: abdominal pain, that rebound tenderness, shallow breathing, fever, tachypnea, tachycardia. Tachypnea is fast breathing, tachycardia is fast heart rate, nausea and vomiting, increased white blood cell count. Our biggest complication, sepsis. That's what we're really worried about. We're worried about the infection of the entire body, especially in that area. Some places we'll call them hot bellies, is what they call it. What that means is the belly is a hot area for that kind of infection and that sepsis. We're going to watch for hypovolemic shock and abscess formation, as well as respiratory distress. Treatment: IV fluids and IV antibiotics, the big ones. We're going to pour that into the patient, really try to do multiple IV antibiotics to keep any kind of infection or reducing infection. We're going to treat pain, nausea, and vomiting. We're going to monitor those vital signs. We want to watch for any kind of signs of sepsis. Your first sign of sepsis is usually high respiratory rate, followed by high heart rate and fever, and your last vital sign change is low blood pressure. Once you get low blood pressure, that is starting to become more of a medical emergency. So you're going to try to watch for the others first, but low blood pressure is usually the end all. We're going to watch intake and output. Something we'll talk about later is the kidneys. The kidneys need a lot of blood flow to produce urine output. If all of a sudden your urine output decreases, it usually is a sign that your blood pressure is so low that it's not perfusing your kidneys. So when we talk about sepsis specifically, one of your end-alls is low blood pressure, which causes your other organs to failure, like your kidneys. So we're monitoring intake and output, because if we start to lose kidney function, we're going to start being concerned. That's where we're going to start giving medications to raise their blood pressure, because we want that perfusion to those kidneys to keep all the organs functioning. A lot of the times, these patients are NPO and often have NG tube placement. This is a great visual of peritonitis, or the hot belly. I like it. I think it gives a really good picture, so feel free to use this to study. Chronic abdominal pain. Really the two that we hear of is irritable bowel syndrome or inflammatory bowel disease, such as Crohn's and ulcerative colitis. These are ones that don't really have a cure. They're not that short-term appendectomy, like they have appendicitis, we're going to remove their appendix and everything's solved. These are long-term issues that these people have. IBS, or irritable bowel syndrome, it's a chronic abdominal pain and or alteration in bowel function. There really is kind of this debate of what causes IBS, because there's not really one specific diagnostic criteria. So it could be caused from physiological stressors, a history of GI infections, dietary intolerances, for example, gluten. So really, since there's no way to pinpoint exactly what IBS is, it's usually diagnosed by symptoms or rule out of other issues. So we're going to look at all the other issues it could possibly be. If nothing else is the tell, then we're going to diagnose it as IBS. Symptoms include pain, bloating, nausea, bowel urgency, bowel elimination changes, mucus, fatigue, and really our goal is to change the diet and remove foods and deal with stress and some drug therapies that are becoming more approved as time goes on, as this is more studied. We'll get in more to Crohn's and ulcerative colitis. Please spend some time in Crohn's and ulcerative colitis because this is a big point in exams and in NCLEX in the future. All right, inflammatory bowel disease. This is IBD, and a lot of people confuse IBS and IBD. So we're focused on inflammatory bowel disease. This is characterized by chronic, recurrent inflammation of the intestinal tract. This could be a period of remission that is interspaced with periods of exacerbation. They get better, they get worse. They get better, they get worse. There really is no exact cause, and there is no cure. So really there's two types of IBD. There's ulcerative colitis and Crohn's disease. Ulcerative colitis is known not to be as bad as Crohn's disease. Ulcerative colitis is the inflammation and ulceration of the colon and rectum, so there's lower GI, where Crohn's disease is inflammation of really any segment of the GI tract from mouth to anus. Really can occur at any age. It equally affects both sexes. They are immunologically related disorders, so that's why we all kind of put them under IBD, but they are different. So this is a picture of Crohn's versus ulcerative colitis. As you can see, ulcerative colitis is that lower kind of section of the colon. Crohn's disease really can happen anywhere. It can be in multiple places. So you can see that bright red different areas. It really involves other areas, and it involves the small intestine, where ulcerative colitis only involves the lower intestine. Signs and symptoms are usually the same. You're going to have diarrhea, bloody stools. Usually bloody stools are most common in ulcerative colitis, being that lower GI, so you see the blood in the stool more. Weight loss, it's more common in Crohn's disease because if you think inflammation of the small intestine and impairs nutrient absorption. That small intestine, really the big job of it is to absorb all those nutrients. So if you're not getting that absorption of nutrients, then you're more likely to lose weight. They have abdominal pain, fever, usually due to inflammation, and fatigue. So complications, there can be many types of complications of that GI tract. You can have a hemorrhage, different kind of bleeding. So you have anemia, which is usually corrected via blood transfusions and iron supplements. You could see strictures, so there's so much inflammation of that area, it actually strictures, so it becomes a smaller passage for it to go through. You can see perforation, so it kind of eats through the entire bowel, goes into that peritoneal area, which is again a cause of peritonitis, which we talked about earlier. You can see some fistulas. Fistulas are some kind of tunnel from one area to another. So perineal abscess and fistulas. So this can occur usually with Crohn's patients, usually 1/3 of Crohn's patients. Some patients develop skin tags kind of around the anus. And then some people get severity of infection and inflammation. Sometimes it's called C. diff, which they're more likely to get because of their autoimmune increased immunology. And sometimes they get what's called toxic megacolon. They're at risk for perforation, may need emergent colectomy. A colectomy is an excision of part or all of the colon. Toxic megacolon is more common in ulcerative colitis because it's that lower GI tract. Megacolon really means chronic dilation of the colon, so it gets very large and can cause an issue for perforation and peritonitis again. So again, Crohn's disease, it really is inflammation, involves all layers of the bowel wall. It can really occur anywhere in the GI tract and occurs most commonly in the terminal ileum and colon. The terminal ileum is that distal end of the small intestine right before it connects to the colon. So with Crohn's, you can see what we call skip lesions. This is like the picture before where it's segments of normal bowel, then it has diseased bowel, then normal, then disease, so it kind of skips around. Ulcerations are deep and longitudinal and penetrate between islands of inflamed edematous mucosa. So it kind of has this cobblestone appearance where it's better, then you have these deep areas of ulceration, and then better, and it does look like cobblestones. So here's a good picture of that cobblestone kind of appearance. Um, they are at more risk for things like abscesses and strictures. Stricture is an area inflammation that may cause bowel obstruction, so it's that narrowing, the tunneling down. So nothing like having a Crohn's flare up along with a bowel obstruction. Because inflammation can go through the entire wall, microscopic leaks can allow bowel contents to enter the bowel cavity. As you can see in this picture in the very far right corner, that's a little abscess that forms. So they had this like narrow tunneled area that broke through and caused an abscess. And then if that abscess broke into the intestines and the peritoneal, then it caused peritonitis. So I was talking about earlier, these fistulas, they can develop really anywhere. It could be adjacent areas of the bowel, between the bowel and the bladder, and then the bowel and the vagina or the uterus. So UTIs are usually the first sign of some kind of bowel or bladder fistula. There's usually feces seen actually within the urine sample. So a fistula from the bowel goes all the way to the ureter, and that's where it kind of connects. So it's not something you can visually see, it's more internal. Fistulas between the bowel and the vagina allow feces to leak out through the vagina, and feces leak into the skin, and usually we see like skin breakdown and skin fistulas. Um, these are hard for women a lot of times to explain. A lot of them will say like I'm 6 years old and I'm on my period or something like that, and it's actually not period fluid, it's actually bowel. So that's usually something we need to ask for of what normal looks for them. This is a good picture of a internal fistula. So as you can see, kind of that bowel breakdown or the lining that breaks down, and so you have a passageway from one bowel to the other or one section to the other. So we're talking about the common symptoms: diarrhea, crampy abdomen. Usually the less common that we see, and it's usually down the road, is weight loss due to like the malabsorption, rectal bleeding, which usually is more of a ulcerative colitis, but can occasionally happen in Crohn's, and then fever and other systemic symptoms. So the complications of Crohn's disease, one of the main ones is nutritional problems, especially when the terminal ileum is involved. And a reminder that terminal ileum is the last part of the small intestine that connects to the large intestines. This is a huge fat absorption and calorie absorptions, and so really you'll see a fat malabsorption and anemia occur because bile salts and cobalamin are absorbed exclusively in that terminal ileum. So really you're going to see a lot of nutritional issues, and they have a higher risk for small intestinal cancer. So ulcerative colitis, the pattern of inflammation is it's really a disease of the mucosal layer of the colon and rectum, which is less of a deep layer than, say, Crohn's. It usually starts in the rectum and moves in a continuum manner towards the cecum. So as you can see in this picture, it starts in the lower part of the rectum and it moves up, and it usually goes no higher than that cecum. The inflammation and ulceration occurs in the mucosal layer, which is the innermost layer of the bowel, not really as deep. Because it doesn't go as deep, you really won't see issues like fistulas and abscesses, which are pretty rare compared to Crohn's disease. You'll see diarrhea with large amounts of fluid and electrolyte losses. The breakdown of cells results in a protein loss through the stool and areas of inflamed mucosa. There's also like pseudopolyps, which are tongue-like projections into the bowel lumen that can lead to, say, a bowel obstruction. So with like the mild disease, you're still going to see a lot of bloody diarrhea. It could be anywhere from several times a day to up to 20 times of bloody diarrhea a day. So you can see where dehydration and anemia could be an issue. With mild disease, diarrhea may consist of no more than 4 semi-formed stools daily that contains small amounts of blood, and really the patient may have no other manifestations, so they may not even be seen or want to come in to get checked. In moderate disease, there's an increase in stool output, really up to 10 times a day. You see increased bleeding and more systemic symptoms such as fever, malaise, mild anemia, and anorexia. But in severe disease, the diarrhea is bloody, contains mucus, and occurs 10 to 20 times a day. This is where you could see weight loss and dehydration really occur. Abdominal pain can be anywhere from mild to severe. The pain may vary from like mild lower abdominal cramping associated just with the diarrhea to severe constant pain associated with like acute perforations. In the severe form of the disease, you're going to see fever, rapid weight loss of up to greater than 10% of the total body weight. You're going to see anemia due to the bloody stools, tachycardia, and dehydration. This is really the severe form, and not a lot of people get that. So really, these people can be borderline, like are they Crohn's or are they ulcerative colitis? And it really takes getting a scope and finding the disease bowel's location to really diagnose. Goals of treatment, NPO, you really want to rest those bowels. Any kind of food that's going to cause further inflammation could be worse. Really, because the cause is unknown, treatment really relies on drugs to treat the inflammation and maintain remission. There really can be anywhere from a variety of drugs, and hospitalization really is only indicated if the patient does not respond to drug therapy. Most of these people can be taken care of outpatient. If the disease is severe and when complications occur, they may also be hospitalized. Really, we want to combat infections, correct malnutrition, alleviate stress, relieve symptoms, and improve quality of life. Exacerbations are debilitating and frequent, which leads to like complication of massive bleeding, perforation, strictures or obstruction, and tissues indication of dysplasia or carcinoma. Our goal is to really try to hit it from the beginning to decrease these exacerbations, and surgery really is only indicated if treatment fails. Here are some of the list of drugs that can be used for ulcerative colitis. And really, it is not to cure, it is to induce and maintain remission. Really, the drugs are chosen on basis of severity and location of inflammation. Usually a step-down approach is done where it uses biological and targeted therapy first. We're going to kind of hit as much as we can to figure out what can help. We use less toxic therapies and medications because we really don't want to use them if we don't have to. And if we do need to, it's really because no other therapies have worked. Really, biological and targeted agents do not work for everyone. It is costly, it can have side effects, it may produce allergic reactions, and the big one is its weakened immune systems lead to complications. So if you got to go risk versus benefits. And these drugs are most effective when they're given in regular intervals, so they really can't like start the meds, stop the meds, start the meds, stop the meds. Because that's really not going to be effective to them. So if they are going to have issues with payment, if they're going to have issues with immunology and not wanting to take these meds, then that's when we probably don't want to do these therapies unless something else. Really, we need to educate them very much about all the side effects, what they need to do, and these risk of high infections, because they're going to have to avoid large crowds and be taught to wash hands frequently because they are going to have a compromised immune system. Nutritional therapy during acute exacerbations, really regular diet may not be tolerated. We want to maybe if they're having severe inflammation, we start them NPO, but we're going to go from NPO to like liquid enteral feedings, high in calorie nutrients, lactose free, and easily absorbed where their GI system is not going to be processing as much. Really, parenteral nutrition is not as preferred because atrophy of the gut and bacterial overgrowth occur when the GI system is not used. So we're not wanting to not use the GI system at all. We want to give them items that are easily to absorb nutritionally. And then regular foods are reintroduced gradually. Really, we want to look for food intolerances and sensitivities and educate the patients to not go towards those diets and those food options. Surgical therapy is really a last resort and usually only in Crohn's disease, although I've seen a couple of ulcerative colitis patients that have gotten this. It's most commonly performed for complications such as strictures, obstructions, bleeding, and fistulas, and this is when we tried every other treatment. Maybe they've had multiple obstructions and we've not been able to find a way to get past that. When segments of the intestine are removed, the remaining intestines is re-anatomized, which means they reconnect those intestines. Sadly, unfortunately, the disease can often reoccur at those sites, so it is not a cure. It might just kind of help in the short term, but you might see complications further down. Most patients sadly eventually require some kind of surgery, and surgery produces remission, but recurrence rate is high. You also might see what's called short bowel syndrome. This is from repeated removal of sections of the small intestine. It really is when there is too little small intestine surface area to maintain life. So they cannot absorb enough nutrition because their small intestine is so small. That's why we really want to do surgery as a last resort, because if most patients end up having surgery, we want to decrease the amount of surgeries that they have so they don't get the short bowel syndrome. It means lifetime parenteral nutrition is necessary for survival. Because ulcerative colitis affects only the colon, these different kind of surgery therapy can be curative, though they can have flare-ups at the surgery site still occasionally. So it's really important that the provider gets or the surgeon gets the entire colon that is effective. Ulcerative colitis can be cured with a total colectomy due to the fact that the colon and rectum are not necessary for survival, but most of the time this means that the individual will have a colostomy. So that is a huge lifestyle change. Although when these patients have long-term side effects, pain issues, sometimes a colostomy is worth it. I've seen patients that really have life has improved with a colostomy.